Well, it really was a team effort, as Mary and Lisa have said. I would like to talk about the medical aspect, just doing medicine. Doing cross-cultural medicine in a language you can't comprehend at all is very difficult. Even with translators who, my translator, her English got better over the time. But it was a learning process for all of us. And that's kind of part of the fun and part of the challenge. But one of the things I find interesting about doing cross-cultural medicine, and I first noticed it when I did medical work in Honduras, is that when you're dealing with a population of people who have no expectation of relief in their lives, anything you bring them is good. So when we say, you gave them 60 days worth of ibuprofen, whoop-de-doo, because we can go down and fill our medicine cabinet. They don't ever get any, so if they're going to have 60 days out of the year when they don't have back pain, it's a bonus, because they have no expectation of relief. And I even noticed it when the roads were muddy and people are still walking to work. There's no expectation that that road's going to change. So that was really noticeable to me. And the other thing that I thought was really different about doing American medicine in Tanzania was that there was a really poor understanding by some of the people, some of the patients, what we could provide. They had a very exalted idea of us. American doctors, American medical team, we could probably pretty much fix everything. And there was some real sadnesses associated with that, and they were very accepting when we said we can't do anything, and particularly when we dealt with severely developmentally delayed children, that these very poor, hardworking parents had kept alive, I don't know how, but for maybe 10 or 12 years. And they couldn't walk, or talk, or sit up, or toilet themselves, or eat. So that's pretty amazing. And they would bring them to us, hoping we could give them a pill, or do something that would make them better. And we had to tell them, no, this is how it's going to be forever. So that was sad. So the primary thing I think that I would like to you to know is how marginal the conditions are in which we were working. We here talk about sterile procedures. There we talked about, well, can we get it sort of clean, sort of a cleanish procedure. You're working, when we went to on the out trips in the cattle trucks, as Lisa and Mary said, we took everything we thought we were going to need, and sometimes we in fact had everything we thought we needed. But you're working usually in the churches. Those are the centers of the communities. And dirt floors usually, sometimes windows, sometimes just big squares that the light came in. And with the ubiquitous white, blue, green, sometimes red, plastic chairs. Those plastic chairs are like Coca-Cola. They have taken over the world. So we would form our little stations. You didn't have tables. You didn't have light. You didn't have electricity for the most part. There weren't really very many flat surfaces. You didn't have utensils. You couldn't wash anything out. Any water was what we took, so sometimes you're using your drinking water to rinse off an instrument. Bleach and water in a used water bottle makes a pretty good sterilization unit. So really working in suboptimal conditions and having to improvise. And I would like to tell, we'll start with Lisa. So Carly, the other doctor, had a brilliant idea. She was so much fun. We were a fabulous team. I loved working with her. But we're talking about needing spacers for inhalers. If you guys have ever used an inhaler, they make a spacer, which makes the use of the inhaler much more efficient. We were trying to figure out, well, we really need spacers, because a lot of our patients were really not clear on the concept of inhalers. And there's a lot of respiratory disease, because they're cooking over open fires and that sort of thing. So Carly said, you know, if we used one of these water bottles and we cut out the end of it, we could put the, person on one end and inhaler on the other. So Lisa figured out how to actually do that, because you're cutting across seams in the bottle. That was real awkward. But they were brilliant. We were brilliant. So, but you were really having to improvise. It's like, okay, we don't have that. Well, what would work? If we do this, would that work? You were always having to think outside the box, because pretty much there was no box. We worked with the local medical personnel that the organization has hired. One physician, and we never quite figured out exactly what his training was. He's Tanzania trained, and I think there's at least 3 years past high school. Very, very knowledgeable about malaria and skin fungal diseases, and very not knowledgeable about appropriate use of antibiotics. So we learned about malaria and skin diseases, and he learned about proper way to prescribe antibiotics. What are the conditions that we treated? What did we see? Well, most of the conditions that we saw are the result of poverty, lack of resources, lack of access to the very minimal resources that exist in country, lack of water or availability of water. Most people are walking many miles for water and carrying it back on their heads. Guess who's doing that? The women. Problems with hygiene because there's no water. And issues having to do with really hard work, because if you go into the fields and you're bending down and you're hoeing and weeding and pulling for most of your life, you have musculoskeletal problems. And if you're living in a place where you're working with animals and hand tools and you're having to go lots of different places, you fall down and you break things. And we would see a lot of malaligned, poorly aligned fractures where they had healed crooked. If you're a farmer and your elbow gets broken and it doesn't heal right, your whole livelihood and that of your family is severely compromised. So these aren't just minor things. We would think of some of those things in our culture as not a big deal. We just go to an orthopedic doctor and get it fixed. They can't do that. We did some skin lumps and bumps, and I initially thought, well, what's the big deal about these? But it's the same thing. Like Mary Nielsen, the nurse and team leader, said one day I was taking out a lump on top of this Maasai woman's head, and it was a bloody procedure. Blood doesn't mix well in the dirt of the church floor, but nevertheless, Lisa kept bringing me gauze, and I got it out. But I'm thinking, it wouldn't be a big deal in this country. But if you carry your water on top of your head for your family, and you can't do that, that's a big deal. So that's a life-changing procedure. If you have a mass on your back that prevents your shoulder moving correctly, and we can take it out, which we did, that's a life-transforming procedure. So we have to rethink how we looked at what we're doing. What difference in this person's life will this make? Not how we look at it. We saw a lot of burns, and I think there are some slides of a girl with really horrible burns down her shins. They have a lot of open cooking fires, and you notice how some of the little children are all dressed up in these little frilly dresses, secondhand from the States. They're synthetic, most of them. And they not only catch on fire, they melt against your skin. So I saw this in Tanzania, and I saw it as well in Honduras. We saw a lot of wounds. There's some of me dressing a wound, and I don't remember if I put the original wound there on a foot. Yeah. So you couldn't really schedule sometimes, it's like, yeah, we're going to have devotions, and we're going to have supper, and we're going to do. And then someone comes and said, they need the doctor to come down and look at this little cut on the foot. So we went down and looked at the little cut on the foot, and what it really was a giant machete wound that was all filled up with blood and goo. So each morning, one of us, or two of us would be on a team. We'd have a doc and a nurse, or I think usually. We would go down to the hut where he was staying, the place where he was staying, and clean out his wound and redress it. And quite frankly, had we not been there, I think he would have lost his foot. So machete wounds, not something I had to ever really deal with here. So a lot of malaria. If a person comes in with a fever and sweating, it's basically malaria until proven otherwise there. So malaria is pretty endemic. A lot of skin diseases. It's, they have a rainy season and a dry season and no access to hygiene really. So the skin just gets hammered. A lot of fungal diseases, a lot of, you see in the kids, I think I've got one picture in the slideshow of some kid whose head had a fungal disease, and then it had got a secondary infection. Now here, if that happened, we'd call it impetigo, and put a little antibiotic ointment on and clean it up and give them some pills and they'd be well. They can't do that there, so it's a huge deal. To tell somebody you need to wash this and clean this twice a day, that's a huge deal because your water's 5 miles away. And as Lisa said, or Mary, we wormed everybody because worms are a huge issue there. One of the additional things, as Mary talked about, most of the, or Lisa, most of the members of this team paid for most or all of their cost to go, so that we could use the money we fundraised prior to going for medicines and supplies. I think you talked about that, Lisa. At the end of the trip, the money that we had not used in country to buy additional medications or supplies, we divided out according to need to provide for additional care that we couldn't provide. There are some other resources, like for example, in a little while there was going to be a team coming to the Lutheran hospital that happened to have a surgeon in it. So anybody that needed surgery, we're going to line them out there. A dental extraction, which our dental hygienists did a lot of dental extractions, but some of them are more complicated. They need more work. It's about $10, so that's just outrageously expensive. Gallbladder, I think we decided was $200 or $250, something like that. So we allocated that money for these people whom we had seen that we could not definitively care for. We allocated it, and there's a kind of a system that goes through the organization and the local doctor so that it gets to the right person and gets used for the appropriate thing, and the organization gets receipts back. They're still working on getting that really all lined out, because Africa doesn't really work like that usually, like you want a receipt. But we're working on that to have accountability, since most of the funding is from the U.S. and U.S. citizens expect to have some knowledge of where their money went. But we funded several surgeries, some cataract surgeries. There's a couple masses that you see. I think there's one girl with a big mass right here. And we're waiting on some of those reports. Dr. Kassam, the doctor that the clinic has hired, that the organization has hired to work in the clinic, is really trying to get the follow-up and the data. One of the more interesting cases we saw was a wound in a woman with a big arm wound and infection. It really looked horrible. And the other doctor and I, Carly, said, well, it's a terrible infection. It's cellulitis. We'll put her on a bunch of antibiotics, put her on 3 antibiotics, which is pretty standard care here in the U.S. And so we kind of talked about what it could be. Well, we had no idea what it really was, which was cutaneous, meaning of the skin, anthrax. Now, that was never in our differential diagnosis, meaning we didn't think about it because, quite frankly, other than having read about it, I have never seen it. Fortunately, the antibiotics we chose were excellent. And we probably saved her life too. But when we had to send people to additional care, whether after we left or while we were there, we also needed to fund their transportation. The main mode of transportation for the locals is on the piki-piki, which is little motorbikes operated by a teenager, 20-something guy. And you'd see these women with their baskets and their cloth all around them, perched on the back of the piki-piki. And a ride could be, if it was a distance, it could be up to 25 cents, equal to. And that's how people got to and from clinics and hospitals, or someone went with them on public transportation, which is not terribly good. So the challenges are many. And the good thing is that this organization goes to the same place on a repetitive basis. So they're starting to make some changes. The fact that there actually is a physical building now is huge. There's an actual real doctor. That's huge. And it would be good if it had running water, of course, but we're working, the organization is working on continually upgrading the services and the way in which it provides the services. And you're working in a culture that doesn't necessarily see things the same way you do, or you see things how they do, so there are some challenges there. And you always have to be culturally sensitive. I was telling some of the people that were in here earlier that one of my funniest moments was, well, the funniest moment was when somebody said you could have toast, and I went, well, I saw the toaster and I saw the bread, but I never really put the two together. But I had a translator, Obed, and from the Bible, and he spoke Spanish, and I speak a little Spanish, and his English was pretty good, but he said something in Spanish one day, and I answered him in Spanish. So from then on, if he was translating for me, they would speak Swahili to him, he would speak Spanish to me, and I would write the note in English. In Tanzania. that's pretty much what I wanted to talk about. Dental care. We're going to talk about the fact dental care is huge. One of the biggest entry points for infection to the human body is through gums. And so if you have poor dental care, you're more likely to have valvular heart disease, septicemia, lots of problems. So dental care is huge. And the reason that you want every individual to have their own toothbrush is if gums bleed, and they do all the time, and you're sharing a toothbrush in a country that has a fairly high HIV rate, you're transmitting the disease. It's really important to do no harm. So we'll open it up to questions, if you have any questions or comments.